A lot of previous questions have been asked in different universities. They ask about the pleural TB also. They ask about the pulmonary tuberculosis also, and the complications of tuberculosis in the lungs, right? Including fibrosis, including cavitatory tuberculosis and hemoptysis. The causes of hemoptysis due to tuberculosis itself is a question in itself, right? And a number of other questions which are based on anti-tubercular therapy and other manifestations of pulmonary tuberculosis. This class, I will limit myself to pulmonary tuberculosis and maybe a little discussion about pleural tuberculosis. But extrapulmonary tuberculosis, I will not cover in this session. We'll cover it in a separate session as and when the systems arise. So meningitis, TB, tubercular meningitis will cover in CNS, and likewise genitourinary tuberculosis we can cover in renal system and so on. Okay, so coming to Mycobacterium tuberculosis, you know it's a type of bacillus which has mycolic acid, and that is why it has this acid fastness, right? So we know about its acid fast property. You know that because of the mycolic acid, it doesn't allow the acid fast or the Zeal-Nielsen stain to escape, and that's why you get a Zeal-Nielsen positivity. So Zeal-Nielsen positivity or acid fastness is something that is unique to the tubercular bacilli. There are other bacteria also or other organisms also which can have this acid fastness, including microbes such as nocardia. So important because other acid fast bacilli like nocardia and Legionella mcdaddy. Okay, Legionella mcdaddy. So, and we also have cryptosporidiosis, isospora bile. So all these are acid fast. So the importance of this is, especially with nocardia, for example, when a patient has a slightly subacute presentation, maybe a 2-3 weeks history of cough, maybe with low-grade fever, and then there is hemoptysis also. So in India, the first thing we think of is tuberculosis. But we should also keep in mind, if you get a ZN stain positivity, nocardiosis is another possibility or another cause for hemoptysis, very under-recognized cause for hemoptysis, nocardiosis. Okay, so keep that also in mind whenever you come across a subacute case of pulmonary disease with hemoptysis. So we know about the mycolic acid, and we do have antimicrobial or anti-tubercular agents which target this mycolic acid, including INH, right? So that's why it imparts its the mycolic acid is the reason why we call this class of bacteria as mycobacteria. There are other mycobacteria also, but tuberculosis has been something that is the organism has plagued us for several generations, right? And India, the problem of tuberculosis, the burden of tuberculosis has been very high, even though in the West it had come down. And then it came up. In the West, what happened was the tuberculosis incidence came down with good hygiene, with the improvement in the general health standards. But then HIV came. So because of HIV, there was a rise in tuberculosis incidence again. And that brought tuberculosis back into prominence, right? But again, they have also been able to successfully bring down tuberculosis incidence. So it's not like how it is in India. In India, the exposure to tuberculosis is quite high, considering the lack of general hygiene quality in India, the overcrowding, and in general risk factors such as malnutrition, such as uncontrolled diabetes. So all these end up making tuberculosis prevalence remain high. But of course, now the aim is to try and eliminate tuberculosis as early as possible. So that's about the bacillus. Now, what happens when the mycobacterium enters into, when we breathe in the mycobacterium, it can come and get settled into the lung parenchyma. So the mode or the portal of entry for tuberculosis is the lung, and therefore the most common site, the most common disease produced by tuberculosis is going to be in the lungs. So portal of entry is the lungs, and therefore most common site of disease for tuberculosis is site for disease is the lungs. Okay, so pulmonary tuberculosis is the most common manifestation of a tuberculosis disease. But tuberculosis infection means that the person has encountered this bacillus, may be housing the bacillus, may be harboring the bacillus, but not necessarily having a disease manifestation as a result of the bacillus. Okay, so there is a difference between tuberculosis infection and tuberculosis disease. So not all infected individuals will have manifestations of the disease. So you and I, since we are exposed to tuberculosis, right? So if you go to the wards, you will the air in the hospital air itself will have tuberculosis bacillus. That's because there are patients with tuberculosis who are coughing. Either they've already been diagnosed, or they may be patient relatives who have the tuberculosis bacillus within them because they were contacts, close household contacts of patients of tuberculosis. So whenever there is exposure to this tuberculosis bacillus, we will end up having an infection, no doubt. Okay, so all of us may be infected. All of us having been exposed may have infection within us, but we don't necessarily have the tuberculosis disease. That's because it's always a battle. It's a battle between the host immunity, the cell mediated host immunity, and the tuberculosis bacillus. So who gets the upper hand decides whether the person develops disease or not. If the host immunity, cell mediated immunity, is successful in containing the bacillus within the granuloma. So what is the purpose of a granuloma? Why do those macrophages convert themselves into epithelioid cells, and then they attract lymphocytes also, and they end up producing a circumscribed histological lesion called granuloma? So what is the purpose of that? It is to try and contain the bacillus. It should not be spreading. In the meantime, they try and destroy the bacillus also with the caseation that can be generated in those granulomas. So if host immunity is able to contain it, then the manifestations may not be there. Even though there is some minimal amount of inflammation going on, the person may not have obvious manifestations. But if the tuberculosis bacillus instead gains the upper hand, then it can end up producing obvious manifestations. The inflammation will increase. It will not just be a low level inflammation. The level of inflammation will increase, and that will produce manifestations. And therefore, the person may manifest with the different forms of tuberculosis disease. So what's important to know is there is something called a there is a stage of latent tubercular infection, latent TBI or LTBI rather. This means that the person has an infection but doesn't have the disease yet. So this is not so relevant in India. We almost know that all of us, if you visit a crowded area enough number of times, you would be exposed to the bacillus. Okay, not necessarily the hospital itself. So if you are been exposed to a crowded area, that itself is enough, because there would be somebody with tuberculosis infection who is coughing it out, and therefore you are exposed to it. But in the West, let us say in the US, where the tuberculosis disease incidence and the infection incidence is also very low, for them it's a big deal. So any of you who are planning to perhaps apply for US degrees or pursuing USMLE and all, so when you do go for an observership or you want to do a clerkship, you may be asked to undergo an interferon gamma release assay, so IGRA. So what that would do is would show whether you have been exposed to the tuberculosis bacillus, and therefore do you have the infection, which is for them a big deal. For us, all of us may have the infection, but we need not have the disease unless our immunity has been compromised. For some reason, if the immunity level comes down, then the disease will manifest. Otherwise, we may be able to successfully contain the bacillus as long as it could be lifelong also. So, but for them, even an infection is a big deal. That's why they may request you to undergo or instruct you to undergo an interferon gamma release assay to determine if you have the infection or not. Okay, so what is the important point is not all patients or people who are exposed to the infection will end up developing the disease. The disease will develop when the bacillus gains the upper hand and the immunity levels go down. Okay, so, and the most common site of tuberculosis disease is in the lungs. Beyond the lungs, outside of the lungs, it can affect a number of other sites. The most common extra-pulmonary site of tuberculosis is in the lymph nodes. Okay, so lymphadenopathy, tubercular lymphadenopathy is the most common extra-pulmonary form of tubercular disease. One very important point to remember is pleural tuberculosis, pleural effusion is not pulmonary tuberculosis. It's an extra-pulmonary form of tuberculosis. Okay, so please keep in mind, when a patient has tubercular pleural effusion, it's not considered as a pulmonary tuberculosis, it's an extrapulmonary tuberculosis. That is the second most common site of extrapulmonary tuberculosis. The most common extrapulmonary tuberculosis being lymphadenopathy, tubercular lymphadenopathy. Okay, so basically what's going to happen is there is the tuberculous bacillus is going to attach to the dendritic cells, and from there dendritic cells it will move on to macrophages. It will go inside the macrophages. So the macrophages will now get activated. They have the tuberculous bacillus within them. They have engulfed it, but they're not able to destroy it. It's somehow evading the macrophage mediated destruction. So that is going to, in turn, the macrophage in turn is going to activate lymphocytes, which will again, mainly it's going to be the CD4 lymphocytes, which will mediate a type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction, which is cell mediated, right? So cell mediated immunity is of paramount importance in tuberculosis. If all of us have the infection and we don't have the disease, it's because our cell mediated immunity is protecting us, is controlling or limiting the infection. But if, in addition to this, of course, the macrophages will also get converted into something, modified macrophages, which are known as epithelioid cells. And those epithelioid cells will tend to surround a central area which is filled with caseation necrosis. So all these modified epithelioid cells and lymphocytes, which will gather in a circumscribed lesion, and that is what is known as granuloma. In the center, there may be some amount of necrosis. So caseation necrosis is not exclusive. Caseation means cheese-like, right? So cheese-like necrosis or cheese-like material in midst of this granuloma is not unique to tuberculosis. It can occur in certain fungal infections. It can even occur in certain tumors. Okay, but it most often, whenever we come across caseation necrosis, the top differential has to be tuberculosis. But that being said, even if you get a non-caseating granuloma, it does not exclude tuberculosis. A non-caseating granuloma could also be tuberculosis if the clinical suspicion warrants or deems that the person fits into tuberculosis. We must consider it to be significant also, even if there is no caseation in middle. Okay, so this is what protects us. This is when a person is exposed to the tuberculous bacillus. When there is an initial exposure, the bacillus can get contained within this granuloma and it will not spread anywhere else. Okay, so it may not even mount this much of caseation necrosis also. Okay, very little amount of caseation, and a successful containment of the bacillus within this granuloma will lead to resolution of symptoms, and the person will enter a stage of latent TB. So this is known as primary initial exposure producing containment, most often containment, or sometimes it may be progressive also. But most often the primary tuberculosis would be either asymptomatic or very, very mild disease, followed by a stage of latent tubercular infection. That means the bacillus is there, but the symptoms are not there, the manifestations are not there. Okay, and you can only diagnose this based on tests like either tuberculin skin test, or what is preferable is IgRA, interferon gamma release assay. And if this is, as long as the cell-mediated immunity is working well. If the cell-mediated immunity wanes, then the person may develop disease. Okay, and this disease most often is in the lung. Otherwise, it could even be involving the lymph nodes, the pleura, the genitourinary system, the meninges, and so on. Okay, even TB adrenalitis, TB in the liver, all these could be potential sites for tubercular disease also. Right, so we should be thankful. Most of us will be able to successfully contain the tuberculous bacillus until in the future if our cell-mediated immunity wanes. Right, so this is how it is. Generally, it starts out as primary TB, initial exposure, successful containment of the tubercular bacillus within a small area. Usually, this is known as Ghon's focus. So, Ghon's focus denotes an area of, very good, Arjun, to limit infection. Very good. So, it's an area within the, so initial exposure usually produces a reaction most often in the lower part of the upper lobe, or may even be in the middle lobe. So lower segments of, that is the lower segments of upper, or the upper segments of lower lobe, or even in the middle lobe. So basically, it's not in the apical region, primary tuberculosis. It's not commonly found in the apex of the lung, nor is it in the base of the lung. It's in the mid regions. Okay, that is because that has the best ratio of oxygen and blood supply. So oxygen content of the alveolus and the blood flow for its nutrition to survive, that is the best ratio. That's in the middle. Okay, when you go lower down, the PO, or rather the FiO2 comes down, or rather the alveolar oxygen content comes down, the AA comes down. And if you go into the apex, the blood flow will not be as great. Okay, the oxygen levels are great, but the apical blood flow is not that great. So that is why the middle region is where the initial focus usually tends to get established. This is the primary tuberculosis. And for Ghon's complex is nothing but a combination of Ghon's focus plus lymph nodes. Is that correct? Ghon's focus plus hilar lymphadenopathy and any intervening lymphangitis. So any lymphatics that are intervening between the hilar, interhilar, or between the Ghon's focus and the hilar lymph nodes. Any of those, if they are involved with inflammation, if they're enlarged, then that is known as Ghon's complex. So Ghon's focus is the site of primary tuberculosis in the lung. Generally, it will be subpleural. So Ghon's focus will generally be subpleural. Okay, Ghon's focus will be in the mid regions of the lung, and it will be subpleural. Okay, and it could, because it's subpleural, it could even involve the pleura. So in initial exposure, there may be a Ghon's focus, and this Ghon's focus is nothing but a granuloma. That granuloma has minimum amount of caseation that is sufficient enough to contain the bacillus. Okay, and that granuloma itself has contained the bacillus, but it has this tendency, the macrophage will tend to take it through the lymphatics into the hilar lymph nodes, and that's why they will get involved. So an initial primary tuberculosis will manifest with just a Ghon's focus with or without involved hilar lymphadenopathy, which the combination of these are called Ghon's complex. It may also involve the pleura. Some amount of minimal pleuritis may occur. Generally, this pleuritis is purely hypersensitivity. Okay, I told you tuberculosis itself, the disease itself, is a manifestation of type 4 hypersensitivity. So let us say if this is the lung, okay, and let's say this is the pleura. So if this Ghon's focus, the subpleural focus, is where the bacillus is, so the surrounding tissue will now elicit type 4 hypersensitivity reaction, and this may spill over into the pleura also. Even the pleural tissue might get involved in this hypersensitivity reaction. It's not that the bacillus is here, but because of involvement in the type 4 hypersensitivity, there may be some amount of pleural effusion, or there may not be a pleural effusion. It may just be an inflammation leading to pleuritic type of chest pain. So this is what we commonly encounter in the case of primary tuberculosis, the initial exposure in India. Why I say that is because we do have a BCG vaccination drive, right? So we have BCG vaccines in our universal immunization program. And as a result of that, what does this BCG vaccine, what advantage does this BCG vaccine give us? Why do we give BCG vaccine? Does it protect us from tuberculosis disease entirely? Will, if I have taken BCG vaccine at birth, will it end up giving me lifelong protection against tubercular disease? Okay, I hope I'm audible. BCG vaccine, Basil, up to 15 years. Good. So Aditya has answered up to 15 years. Yeah. So basically, it will give a protection against severe disease. And that too, that protection is highest in the childhood years, especially up to 5 years. Okay. Beyond 5 years, it starts to progressively come down. Even up to 15 years is okay, but it's not as high as when it is still 5 years. So given at birth, the protection against severe disease. So what was happening before BCG vaccine? In India, tuberculosis was so prevalent the exposure, the primary tuberculosis used to occur in children. So even now it occurs in children. It's just that it's asymptomatic now. But in pre-vaccination era, we used to have children developing primary tuberculosis. Children don't have great cell-mediated immunity. It's not matured yet. The immune system hasn't matured yet, and therefore children used to suffer from severe manifestations of progressive primary tuberculosis. We don't see progressive primary tuberculosis these days. We instead see post-primary tuberculosis. But progressive primary tuberculosis could occur in a patient who has developed an initial or a first time exposure to tuberculous bacillus, and their cell-mediated immunity is not great, like in children who haven't been vaccinated, or in others, like for example, advanced HIV, or patients who are taking infliximab. So TNF alpha or anti-TNF alpha monoclonal antibodies, these have a tendency to suppress the cell-mediated immunity, and that can also render a patient to be at risk for developing tuberculosis, severe tuberculosis. Even the primary tuberculosis may be progressive in them. Otherwise, most often what we come across in India is, yes, at children themselves get exposed to tuberculosis, but because of the vaccine, the immunity is sufficient, the cell-mediated immunity is sufficient to at least prevent severe disease like tubercular meningitis. We don't see severe disease as primary tuberculosis in India. So from there, there is a stage of dormancy. The bacillus is now contained within the granuloma, and the cell-mediated immunity has the upper hand. Minimal amount of caseation, no progression. The bacillus has been contained in within that focus. Okay, and therefore we call it latent tubercular infection. So it's common in India, high prevalence areas, and the only way you can detect an infection at this stage is using IgRA, which is preferable to tuberculin skin test. Okay. And post-primary TB, now for some reason, like I said, maybe the patient received infliximab, maybe they ended up developing rheumatoid arthritis or inflammatory bowel disease, and they ended up receiving infliximab. And that infliximab may end up reducing the cell-mediated immunity and causing a reactivation of the tuberculous bacillus. Sometimes there may be a reinfection also. So household contact develop tuberculosis. From them, they may acquire that tuberculosis and they develop a post-primary tuberculosis. So a reactivation or reinfection with the tuberculous bacillus may produce disease, which is known as post-primary TB. It's also known as adult type tuberculosis. Okay, so adult type tuberculosis or post-primary tuberculosis. In which case, now the cell-mediated immunity has waned and the bacillus has gained the upper hand. There's going to be a lot of caseation. So caseation is going to be much higher. Caseation is higher in patients with post-primary tuberculosis. So caseation necrosis basically means death of tissues. So if there's going to be death of tissues, it's going to leave behind a void. And this void or this gap is going to be called in the lung as cavity. So cavitation in the lung is because all that much of lung tissue has been destroyed permanently because of caseation necrosis. Okay, and this is because the cell-mediated immunity has waned, and the necrosis is the last attempt, is the final attempt to try and contain the bacillus, but it's not working. The bacillus is continuing to do the damage. It is necrosis, right? It is dead tissue. It's going to spread. If you're not able to contain it, it's going to spread. So as it spreads, as the volume of caseation increases, the amount of lung tissue getting destroyed increases. That leaves behind cavities. Okay, and there may be some cavities which need to be, if they're small enough, if the caseation is small enough, that small cavity can get re-epithelialized. So re-epithelialization of that cavity can prevent fibrosis. But otherwise, if the cavity is very large, then you can't replace that much of lung tissue. A very large cavity in the lung, how do you regenerate lung tissue to be able to replace such high or such large cavities? You can't. So fibrous tissue now needs to fill up, collagenous fibrous tissue needs to fill up that void. So that is called fibrosis. So lung fibrosis is another sequelae of post-primary tuberculosis. And likewise, calcification. Ultimately, the caseation necrosis may end up getting calcified. Okay, that's called dystrophic calcification. Dystrophic calcification is whenever there's calcification of dead tissue, right? So this may occur in patients of post-primary tuberculosis. So likewise in lymph nodes, so let us say 2 lymph nodes, if they have caseation necrosis, what will happen? The caseous material will start extruding out of them, and because they're adjacent to each other, it will end up fusing them to each other. So that is why these kind of fused lymph nodes, because the caseation is spreading from one lymph node to the other lymph node and causing a fusion of the lymph nodes. What is that called? Typically, if you examine matted lymph nodes, very good, Swara, matted lymph nodes. So whenever you come across matted lymph node, you're examining the cervical, so the cervical lymph nodes. And if you're getting enlarged lymph nodes and they're matted, you can't really make out the discreteness of the lymph nodes. They all seem to be fused with each other. That is because of caseation. The moment you come across matted lymph nodes, it's caseation necrosis, it's tuberculosis. Okay, unless otherwise proved. I told you caseation is not exclusive to tuberculosis, but in India, the only thing that comes to mind when you come across caseation is tuberculosis. Okay, so this is how it proceeds. So there's not a great deal of difference between primary and post-primary. Okay, it's just a matter of whether it was due to an initial exposure or is it because of a reactivation or a re-exposure. That's all. Okay, so otherwise the manifestations may be similar. It all depends on how good is the person's cell-mediated immunity. Cell-mediated immunity is not good, then they will develop the disease even in primary TB. It's just that in India, because of repeated exposures and the presence of a good vaccination program, we don't encounter progressive primary TB as long as the child's cell-mediated immunity good is adequate to prevent severe disease. Right. So this was about the pathophysiology. Now, what are the clinical features of tuberculosis? Just a couple of slides before I show you some scenarios that we'll discuss regarding tuberculosis. So primary tuberculosis, I told you, may not be symptomatic. Very often it is not. It may just present as a flu-like illness. And this too occurs between 3 to 8 weeks after initial exposure to the bacillus. Okay, so 3 to 8 weeks after exposure to the bacillus, to another person who has active tuberculosis, as cavitatory tuberculosis, bringing out tuberculous bacillus in the sputum. Once exposed, 3 to 8 weeks after that, they may develop a primary tuberculosis. That primary tuberculosis most often will not be symptomatic, even if symptomatic, very mild flu-like illness. And this is the time at which they develop tuberculin conversion. So if you do a tuberculin skin test in an unexposed person, previously unexposed person, non-vaccinated person also, in them, if you do a tuberculin skin test, then it will be around the same time that it turns positive that they experience mild flu-like illness. It could just be myalgia, it could just be some amount of dry cough, okay, a fever, that's all, not very troublesome. Okay, and examination findings are usually very, very rare. Okay, primary tuberculosis, just a small Ghon's focus, it's not going to produce much examination finding. Okay, as long as cell-mediated immunity is good. Erythema nodosum could be a manifestation of primary tuberculosis. So you could get the same erythematous tender nodules on the shin that eventually after 4-5 days, they end up becoming violaceous and they become scaly. Okay, that's how it usually progresses, erythema nodosum. So most often erythema nodosum is because of streptococcus infections, but you could get it as a manifestation of primary tuberculosis also. Very rarely, as I said, in patients who are not vaccinated, in children who are not vaccinated, or in patients who have very poor or weak cell-mediated immunity, they can develop miliary tuberculosis. Miliary tuberculosis means when the person has the tuberculous bacillus, so it's entered the lung, it has gained access, it has come into the mid segments of the mid regions of the lung, and from there, it's not getting controlled, it's not getting contained. So it is beginning to spread. It will produce some amount of caseation here, and it will immediately spread. It may spread hematogenously, or it may spread directly, or it may spread to the lymphatics. But basically, it's spreading into the lungs, in different areas of the lung. It's going to spread into the opposite lung also. Okay, and different areas. There's no granuloma formation, hardly any granuloma formation, mainly some amount of caseation necrosis, not enough to contain it. It is only going to lead to spread to other sites. And from here, it will spread to extra-pulmonary sites, including the brain, including the liver. So you can get, splenomegaly or hepatomegaly in patients, or even the bone marrow. All these can get involved in patients of miliary tuberculosis. Again, not common in the setting of primary tuberculosis, unless the patient has a state of immunocompromised state. Okay, so this is how primary tuberculosis could manifest. Again, I did not mention here, but pleura. So patient may have some amount of pleuritic type of chest pain. This is not as a result of the bacillus being in the pleura. Rather, it's a spillover of hypersensitivity reaction to the tuberculosis bacillus. That's all. Okay, so pleuritic type of chest pain, usually self-limiting, even asymptomatic at times. Post-primary tuberculosis, adult type of tuberculosis, there's going to be progressive caseation necrosis. That has happened because the cell-mediated immunity came down, which led to cavitation. So this cavitation, because of the caseation necrosis, will lead to a void in the lung parenchyma. So within the lung parenchyma, now there's a gap. And if this cavitation now communicates, so let us say this is a bronchus, the initial focus has now produced a cavity. Okay, I'm sorry. So it's produced a cavity. Now this cavity will keep increasing as the caseation increases. And finally, it might find its way into the bronchus. So the caseation has found its way into the bronchus, nearby bronchus. So all this material, which contains the bacillus, some dead, some live bacilli, these will now gain access into the bronchus. And from here, once they enter the bronchus, the obvious response will be to cough, right? So when there's an irritation in the bronchus, the person will cough, and this will end up getting spread outside, okay, as droplets. So generally, it's a droplet infection. Droplets are the mode of transmission for tuberculosis. So when the person coughs, those droplets will be carried into the air, and that will linger on for up to 15 minutes also. So close contacts, those who live within the same household, especially in overcrowded conditions, they will be at risk for developing infection with tuberculosis. Whether they develop disease or not depends on their cell-mediated immunity. Okay, so the extrinsic factors are important for infection. The overcrowding, the lack of adequate hygiene, the cough. So exposure to a cavitatory tuberculosis patient or an open TB, we call it open tuberculosis, open TB. Okay, all this is extrinsic factors which are responsible for infection, which is important for infection. Once infected, whether they develop disease or not depends on internal factors, intrinsic factors. How good is the cell-mediated immunity? Okay, how old is the patient? Whether it's too young or too old? How is the nutrition status? Whether the patient has other comorbidities? Whether the patient is taking medications like steroids, like TNF-alpha inhibitors, monoclonal antibodies. So that decides whether the patient develops disease or not. Okay, I told you fibrosis can also occur. So basically, once tissue is dead, anywhere in the body, whenever there is, I'm sorry, Arjun had asked a question, sir, does children vaccinated with BCG have positive IGRA or tuberculin skin test? Very good question, Arjun. So tuberculin skin test, you are going to inject the PPD into into the intradermal space. So tuberculin skin test will elicit vaccine. You asked about vaccine. So BCG. So when you give a BCG vaccine, you will have a positive, you will have a chance of tuberculin skin test being positive. Okay, tuberculin skin test can be positive in patients who have received BCG vaccines, especially in the initial years. Okay, now if I had received my BCG vaccines 35, 40 years ago, I may not test positive right now for tuberculin skin test purely because of the BCG vaccine. Now that I have been working in the hospital and I have been exposed continuously to tuberculosis, that will be the reason why I have a tuberculin skin test being positive. That means I have the infection. But if even in an otherwise unexposed individual, okay, who had never entered a hospital, never been in an overcrowded situation, and had received BCG vaccine in the childhood, them after 30, 40 years, they may not have a positive tuberculin skin test. But in the initial 10, 15, maybe even 20 years, they may have a positive tuberculin skin test because they had received BCG vaccine at birth. Okay, but IGRA is not going to be positive. It's not going to lead to a positive interferon gamma release assay. That is because there is no overlap. Actually the BCG strain is a strain of Mycobacterium bovis, right? So there is an overlap to when you do a tuberculin skin test, it can cross-react with BCG strain. But interferon gamma release assay is very specific to tubercular antigen. That means the Mycobacterium TB antigen, tuberculosis antigen, not the Mycobacterium bovis or BCG strain. Okay, and therefore, IgRA positivity is not going to be linked to a previous BCG vaccine. Tuberculin skin test can be positive in patients who have received, or people who have received BCG vaccine. Okay, the main antigens for IgRA include something called ESAT-6, CFP-10, and TB7.7. So these are very specific to Mycobacterium tuberculosis, and therefore you do not expect a patient who has received BCG vaccine to test positive for IgRA unless they have been exposed to Mycobacterium tuberculosis also. Okay. Yeah. So good question. Moving on, fibrosis would be, so as I was saying, any disease, anytime that there is a disease where the lung or the tissue is destroyed beyond repair, it will result in fibrosis. For example, in the liver. So what happens when a person keeps drinking alcohol continuously? Continuously, liver cells are dying. So the rate at which they are dying, you cannot replace them with normal liver tissue. So what the liver does, it produces fibrosis. So the stellate cells get activated and they lay down they actually get converted into fibroblasts and they lay down fibrous tissue to make up for all the dying liver cells. So whenever the body feels that this tissue is beyond repair, beyond its ability to be replaced, the body will replace it with fibrous tissue. That's what happens in multiple sclerosis. So if you notice, or if you think about it, multiple sclerosis. What is that sclerosis? Sclerosis is nothing but replacement of inflamed neuronal tissue with fibrous tissue. Okay, so whenever the body realizes this tissue cannot be regenerated or cannot be replaced, it's dying too fast, the body will instead replace that tissue with fibrous tissue. Okay, you know about striae gravidarum or striae in general. Whenever a person gains weight very rapidly, the rapid stretching of skin, the demand is so much that you can't keep creating new skin tissue at such fast rate. So instead, the body will create fibrous tissue. So the fibrous tissue is what is striae. Okay, in a patient with Cushing's syndrome, where there's a very rapid distension of skin, or in pregnancy where there's a rapid distension of skin, or some of you who are perhaps doing bodybuilding and all that. So when your biceps volume increases very suddenly, so the skin cannot keep up at that rate. So instead, you will see some amount of striae. So that is fibrous tissue. So that's what happens whenever there is too much of cavitation, cannot be replaced with normal lung tissue. It will get filled up with fibrous tissue. So that will lead to fibrosis of the lung. Okay, and dissemination can result in miliary tuberculosis in post-primary also. So post-primary tuberculosis is generally when we encounter miliary tuberculosis rather than in primary. Primary generally in children who have been vaccinated. Okay, so that is when we encounter primary. Therefore, miliary TB is not very common. Miliary TB is more common in adults who have lost their capacity to mount a cell-mediated immune response against tuberculosis. Okay, so just a word on miliary tuberculosis. If you're asked, there's dissemination of the bacillus. It's not getting contained within a small Ghon's focus. Instead, it is leading to minimal amount of caseation, hardly any granuloma, and it is going to get disseminated. So that is why in such patients, in patients with miliary tuberculosis, if you do a tuberculin skin test, you will not get a positive response. You will get a negative response because tuberculin skin test indicates the ability to mount a cell-mediated immune response against tubercular antigens. Okay, so that is why in miliary tuberculosis, even though the disease is severe, you will not get a positive tuberculin skin test. So you can't use tuberculin skin test for a reliable diagnosis as a reliable parameter to diagnose tuberculosis. Okay, please keep that in mind. It may be false negative, maybe false positive as we discussed because of BCG vaccine. It may be false negative because of very poor cell-mediated immunity, like in miliary tuberculosis, malnutrition, and so on. Okay, so there's going to be dissemination of the bacillus, minute caseation necrosis foci, hardly any granuloma, and finally it may involve several other sites, including the brain and the bone marrow also. Okay, so they may present with, so in miliary tuberculosis, you know how the course is. So they'll have in an initial course of that runs in weeks. Okay, some 1 or 2 weeks, or maybe even longer, 3-4 weeks of gradual decline. So there is a gradual deterioration, but occurring gradually, that suddenly speeds up. Okay, so they were unwell for 2 weeks, 3 weeks. They were having some low-grade fever. They were having loss of appetite and not feeling their usual self, and gradually deteriorating. And then suddenly, over the last two days, they've developed high-grade fever. Now they're feeling very, very weak. They develop breathlessness. So such sudden deterioration which overlaps or which is superimposed on a previous deterioration over weeks. That's how usually miliary tuberculosis will manifest. Okay, leading to sudden aggravation or sudden escalation of or deterioration. Okay, escalation of symptoms or manifestations. That is how it happens in miliary tuberculosis. Okay, and patients will have hepatosplenomegaly. Bone marrow gets involved, so the patients will have pancytopenia also. So unless there's a high index of suspicion, you may miss it, and it can be fatal. Miliary tuberculosis can be fatal. Okay, I already told you extrapulmonary sites. Lymph node is the most common. Beyond this, pleura. So pleural involvement in post-primary tuberculosis, there can be tubercular bacilli within the pleura. Okay, primary tuberculosis, generally the bacillus is within the lung, but the hypersensitivity response has spilled over because it's a subpleural focus. They may have a pleural effusion, some amount of pleuritis or some amount of effusion. But in post-primary tuberculosis, you get bacilli within the lung. Okay, that's why you have to send CBNAT. So CBNAT stands for CBNAT may be positive in 50% of the patients of pleural effusion, tubercular pleural effusion, post-primary tuberculosis. CBNAT will stand for anybody? Cartridge-based. Very good. So cartridge-based nucleic acid amplification test. Very good, Ashik. So other sites include genitourinary. Very good, Swara. Cartridge-based nucleic acid amplification. So that's the other name we give for gene expert, no? Or expert TB. So expert TB RIF. That is the other name for CBNAT. We generally call it CBNAT. So SISTI, very good. Cartridge-based nucleic acid amplification test. So other sites include skeletal, that means the synovium, so synovial fluid, meninges, of course, dreaded. TB meningitis is a dreaded disease. Fortunately, it used to be common in children, but fortunately with vaccination, the incidence has come down quite a lot. Peritoneum, pericardial, it can involve the intestines. Okay, intestinal TB can involve the adrenals, leading to adrenal insufficiency. In fact, the most common cause of primary adrenal insufficiency in India is tuberculosis. Okay, most common cause of primary adrenal insufficiency in India is tuberculosis. Overall, the most common cause of adrenal insufficiency in India is steroid use, exogenous steroid for a long time, and then sudden abrupt withdrawal of that steroid. That will produce adrenal insufficiency. That is a form of tertiary adrenal insufficiency. Okay, so hypothalamus, pituitary, adrenals which are present on the kidney, right? So if the problem lies at this level, it's primary TB. The pituitary level, it's secondary TB. Hypothalamus, it's tertiary TB. So abrupt withdrawal of steroids after prolonged use at high dose, that leads to tertiary adrenal insufficiency. But the most common cause of primary adrenal insufficiency in India is tuberculosis of the adrenal gland. Okay, so I'll just discuss a few clinical scenarios because now they're asking you main question based on clinical scenarios. So your first job is to interpret that scenario to figure out what are they talking about, and only then be able to answer the questions that follow. Okay, so we'll just discuss a few scenarios before we proceed to investigations. So if a 5-year-old child, I'm sorry, adrenal insufficiency, Ashik has asked, adrenal insufficiency means, so adrenal gland, so the kidneys, they are renal. Okay, so they have a gland on top of them, they're called adrenal. So adrenal gland has a cortex and a medulla, right? So adrenal medulla produces catecholamines. Most often it is the epinephrine that is produced in the adrenal medulla, whereas the adrenal cortex has 3 layers, GFR. Okay, zona glomerulosa, zona fasciculata, and zona reticularis. The zona glomerulosa produces aldosterone, mineralocorticoid, aldosterone. Zona fasciculata produces glucocorticoids, that is cortisol, glucocorticoids, cortisol. And reticularis produces androgens. So even in women also it produces androgens. Okay, then that this androgen leads to something called adrenarche in women. Adrenarche. Okay, if you come across that term with regards to puberty. Okay, in puberty we have, or in women, puberty has 3 components: telarche, adrenarche, and menarche. Okay, so adrenarche is the axillary and pubic hair appearance. That is thanks to the adrenal androgens. Okay, but what I meant by adrenal insufficiency is when there is a loss of synthesis or production of adrenal hormones, specifically glucocorticoids. Okay, when there is a loss of synthesis of glucocorticoids from the adrenal cortex, that is called as adrenal insufficiency. It may or may not be accompanied by mineralocorticoid synthesis deficiency, may or may not be associated with catecholamine synthesis also, but primarily adrenal insufficiency means cortisol insufficiency. Okay, so that is what I meant by adrenal insufficiency. And primary adrenal insufficiency means the gland itself, the adrenal gland itself has been damaged. Why is it damaged? In India, the most common cause is tuberculosis of that gland. Okay, I hope that answered your question, Ashik. Okay, so yeah. So what about this scenario? You guys had some time to read this. There's a 5-year-old child presented a low fine crepitus and present in the right axillary area. What do you guys think this could be? So if they give you a scenario like this and then they say, discuss the differential diagnosis, or they say, or how do you manage such a patient? So that's why I thought I'll put up the scenarios to see if you guys are comfortable with deciphering them. Very good answers. Arjuna said pneumonia, TB, excellent. Saila has said pneumonia, Swara, atypical pneumonia. Shishti has said pneumonia upper lobe. Okay, very specifically, Shishti said upper lobe. I'm a little curious. What was the information in the scenario which made you narrow it down to the upper lobe? Examination would help being able to say confidently it's upper lobe. Otherwise, if you had a particular thought behind saying upper lobe, then please do share it. Otherwise, you guys have given a very good answer. So just because we are doing a class based on tuberculosis does not mean it has to be, the answer has to be tuberculosis. Child has presented with low grade fever, minimal productive cough since 1 week. Okay, so she said probably the creps in axillary region. Very good. Okay, not bad. Nice, nice. Good answer. Good answer. So axillary region actually has a representation of all three lobes. This is the one area where you can get findings of upper lobe also, middle lobe also, and lower lobe also. But nice answer, very nice answer. Axillary findings may be because of an upper lobe lesion also. Good, good. But uh, regarding the differentials, yes, atypical pneumonia, as some of you have said, very good answer. It could be atypical pneumonia, mycoplasma being the most common cause. Of course, 5 years, no? So by 5 years, the causes become little more towards the community-acquired pneumonia causes. And again, atypical pneumonia, mycoplasma is the most common cause. It could be this also. Or it could be, if we have to keep a differential, like Arjun has said, TB, primary TB. So primary tuberculosis could manifest like this with a very flu-like symptom, not very, what do you say, it's not aggressive, okay, it's not very damaging, but the child has symptoms and is continued over a week. So the thing about atypical pneumonia is continuing for an entire week becomes a little unlikely. Okay, so whenever you get 1 week, 1 week is borderline. If you get a patient who has had 2 weeks of fever, dry cough like this, you automatically start thinking more towards tuberculosis and less towards bacterial pneumonia, typical or atypical. Okay, so 1 week can be okay for both. Atypical pneumonia also okay, agreed. Primary tuberculosis also okay. Okay, but if it was less than 1 week, tuberculosis would have become less probable. Whereas if it was towards 2 weeks, 3 weeks means definitely tuberculosis more probable. Okay, so good, all of you got that right. Primary tuberculosis was what I was looking for a 5-year-old, a child who's been exposed to tuberculosis bacillus and now mounting the initial response. The Ghon's focus is forming, the macrophages are busy trying to combat and control that bacillus. That's why the child has minimal symptoms, minimal low-grade fever. Okay, good answers. So if you can appreciate in the X-ray, These are hilar lymph nodes. So bilateral hilar lymphadenopathy. So bilateral hilar lymphadenopathy, and if this is accompanied by uh, Ghon's focus is in the mid parts of the lungs. Okay, so either the lower part of the upper lobe or the upper part of the lower lobe or in the middle lobe. If there is a focus, a very small granuloma, that is the initial focus, initial site. It will be subpleural, okay, just beneath the pleura, towards the peripheral areas of the lung. That in combination is known as Ghon's complex. Okay, so bilateral hilar lymphadenopathy, you should also keep a differential diagnosis of sarcoidosis and lymphoma. If you are sure that there is a lung focus along with the hilar lymph nodes, then you can think of either tuberculosis or sarcoidosis. Lymphoma would only be for the lymphadenopathy, not for a lung lesion. Okay. Yeah. Are the creps usually heard in atypical pneumonia? Yeah. Arjun has asked a very valid question. Crepitation, the findings are not as prominent as in lobar pneumonia. So the thing with atypical pneumonia, no, they will present, let us say, with just some amount of headache, low grade fever. So they'll come with low grade fever, they'll come with headache and myalgia. You're not sure. You're thinking this is just a flu or just an upper respiratory infection. Also, they may have cough, dry cough. Okay, not even productive cough, dry cough, myalgia, maybe some loose stools. Okay, you're not really thinking of a pneumonia at all based on these many symptoms. And then you auscultate the chest and then you find some crepitations. That is when you start thinking, okay, this might be atypical pneumonia. So until you auscultated and you found that there are creps, the involvement of the lung was in total doubt, because all they had was dry cough. They had very non-specific symptoms which are not really localizing to the lung. The patient might have come with loose stools also. The dry cough could be very well due to an upper respiratory pathology. Okay, could be because of a pharyngeal involvement. Even sinusitis can produce dry cough. Okay, but the fact that you found fine crackles on auscultation now tilts the diagnosis towards atypical pneumonia. So yes, crepitations are definitely heard in atypical pneumonia, but not as prominent as in lobar pneumonia or bronchopneumonia. Okay, bronchopneumonia very, very prominent. Saila has asked, lymph nodes in TB are compressed or not? Compressed meaning, do they compress the surrounding structures? Is that what you wanted to ask, Saila? If that's what you wanted to ask, yes, they do. When the lymph nodes are enlarging, no, they will compress surrounding structures. So what that can do, no, it can compress the enlarging lymph node. It can end up compressing the surrounding bronchus, and because of that compression of the bronchus, it can lead to atelectasis. So if there is a total compression of the bronchus, it can lead to atelectasis distally. That means collapse of the lung distally. Or if it is a partial obstruction, it can predispose to bronchiectasis, because there is going to be some amount of infection that settles, and this will end up leading to weakening of the bronchial wall and leading to bronchiectasis. It can also lead to, now, atelectasis. One of the specific forms of atelectasis, because of this tuberculous lymph node compressing on the bronchus, is known as Brock syndrome. Any idea what is Brock syndrome? Voice not clear, I'm sorry. Now, is it better? Brock syndrome. Brock syndrome is also known as middle lobe syndrome. Okay, so middle lobe syndrome, because of the compression of the enlarged lymph nodes, they are generally in very close proximity to the middle bronchus, right middle bronchus. So as a result of that, when there is compression over the bronchus of the middle lobe, it leads to collapse of the right middle lobe. So that is what is called Brock syndrome. Okay, that can occur as a result of the expanding lymph nodes. Definitely, it will be compressive. Okay, that's a good question by Sela. right? So this is about the X-ray that you may find in primary tuberculosis. It's not common. In fact, see, such grossly enlarged hilar lymph nodes, very, very unusual in primary tuberculosis. I just put up the X-ray for representation. You may not notice such grossly enlarged lymph nodes in primary tuberculosis. It will just be on histology that you'll be able to really tell that yes, there is some amount of uh, inflammatory reaction within the enlarged lymph nodes, hilar lymph nodes. Okay, whenever you see very prominent hilar lymph nodes, you should not really think of primary tuberculosis. It may be the other differentials like sarcoidosis or lymphomas. Okay, what about this scenario? A 38-year-old laborer complains of cough with expectoration since 3 weeks, evening rise of body temperature and loss of appetite, right supraclavicular lymph nodes, enlarged, tender, and matted. This one word is very, very important, right? So up until there, you could have had some differentials, even though it's quite the illness seems to be dragging on for 3 weeks and all, but still, you might have had other differentials. But as soon as this word came, the diagnosis becomes very much limited, very restricted to tuberculosis, right? So the patient definitely has tuberculosis. Lymph nodes are definitely involved. So is it a pure extrapulmonary tuberculosis? There is cough with expectoration. So since there is cough with expectoration, you have to presume or suspect that the patient also has pulmonary TB, pulmonary tuberculosis with an extrapulmonary manifestation also. Extrapulmonary manifestation. Okay, and the evening rise of temperature is classic. That's because very low level of inflammation. No, I was talking about cortisol. Cortisol has a diurnal pattern to it. Okay, the highest level of cortisol is generally around 8 a.m. and the lowest level is towards midnight. Okay, so what happens when there's a very low level of inflammation? Low level of inflammation, low amount of TNF alpha being produced, interferon gamma being produced. So in the early morning hours, the cortisol will be able to successfully suppress this inflammation. So fever will not be there. So morning times, the fever is not there. Towards the evening, since the cortisol, you all know, it has anti-inflammatory action. No, it's a steroid. It's a natural steroid synthesized within the adrenals. So it's supposed to be anti-inflammatory. So it will suppress the fever in the mornings. In the evening, the temperature starts going up. So evening rise of temperature is a classical description for any condition which produces low-grade inflammation. It's not specific to TB. Low-grade inflammation, patients may have evening rise of temperature to do with cortisol, diurnal variation of cortisol. Okay, so low-grade inflammation could be seen in tuberculosis. Any idea which disease do we say B symptoms? Have you heard of B symptoms? B symptoms in which disease? So one of the B symptoms is night sweats, fever, unexplained fever. So basically, all that is a part of fever, weight loss. Very good. Fever, weight loss, unexplained fever, lymphoma. Excellent, Saila. So Srishti is also given the answer. So these are B symptoms, which also are similar like this. Low-grade inflammation. Lymphoma also will produce some lymphokines. All the malignant lymphoma cells, they elaborate some amount of lymphokines. So there is a low-grade inflammation, low level of inflammation even in lymphoma, which towards the night, no, when there is defervescence, when the fever starts going down, middle of the night, cortisol levels are rising, the fever starts coming down, there is defervescence, they'll have night sweats. Okay, so this is not exclusive to tuberculosis. Evening rise, night sweats, these are not exclusive to tuberculosis. But yes, gives a high suspicion when they are present. Okay, so this kind of an X-ray where you see such patchy consolidation. Okay, patchy consolidation. It's not like a lobar pattern. It's very intermittent. Okay, it's there in some places only. So this kind of patchy opacities when you notice on an X-ray, it always makes you think of tuberculosis. Okay, generally post-primary tuberculosis when it is multiple. Multiple means usually post-primary. Primary tuberculosis, one single Ghon's focus. Okay. Yeah, another scenario, 58-year-old uncontrolled diabetes mellitus, dry cough since 2 months, denies having fever, Examination, trachea is deviated to left. Chest expansion on left hemithorax is 1 centimeter lesser than the right. What do you think is the diagnosis? So important informations are, okay, the person definitely has a risk for cell-mediated immunity to be diminished. Now he has dry cough since 2 months. Okay, no fever. Trachea is deviated to the left and hemithorax expansion is less on the left side. Could this be TB pleural effusion? TB pleural effusion also, yeah, Aditya has said, okay, Arjun has said, very good. TB pleural effusion will also produce tracheal deviation, yes. Trachea is deviated. It will also produce reduced hemithorax expansion. It will also produce dry cough with or without fever. Okay, all these do fit into tubercular effusion. Malignancy. Okay, Shaila has said malignancy. What? Why did you think of a malignancy? So malignancy could be in the form could take different forms. Malignancy could lead to a malignant pleural effusion. Malignancy could lead to a collapse of the lung. Malignancy can lead to a consolidation, a non-resolving consolidation, non-resolving pneumonia type picture also. So malignancy is the etiology. What is the pathology? Is it a malignant tubercular effusion that you are pointing towards or denoting towards? Meantime, I will say the patient has fibrosis. Anybody agrees with me? I will say the patient has left lung fibrosis. Do you guys agree or do you feel unlikely it must be pleural effusion only? The clue to answering this, okay, Arjun has said no fever due to compromised immunity due to diabetes. Okay, yes, it's possible. That's also possible. So a patient who has some low level of inflammation, they may not have obvious fever. Okay, so especially in patients with low cell-mediated immunity, the amount of inflammation mounted, immune response mounted is less. So fever may not be as high, may have a low-grade fever. Good point, Arjun. Shishti has said, can it be atelectasis? Why do you say so? Why did you think of atelectasis in this patient? Okay, I'll give you two inputs, then you can yourselves decide. Okay, one point is, please remember 2 months history. So it's a chronic history. Patient with chronic history, would atelectasis be expected or do you feel atelectasis is an acute event? Okay, a patient's lung has collapsed. Do you think they can manage for 2 months before finally seeking medical attention? Or, yes, good. Shishti has said acute event. So the fact that it's a longer history goes against atelectasis. Acute event, very good. The second point I want to highlight is look at which side the trachea has deviated and which side is the hemithorax expansion less. So basis for this question is when there is a pleural effusion, if there's a unilateral pleural effusion, would the trachea deviate towards ipsilateral side or would it deviate to the opposite side, the contralateral side? So if you're saying the hemithorax expansion is reduced on the left side, if it was because of a pleural effusion, where would the trachea deviate? Would it be towards the left, as in this case, or should it have deviated to the right, the opposite side? Opposite side. Good. So I said opposite side. Arjun has also said opposite side. So if this was reduced hemithorax expansion due to pleural effusion, you would expect, if this was on the left side, then you would expect that the trachea would have deviated towards the right. But instead here, what they've given is trachea has also deviated to the left. Both are on the left. The pathology is on the left. Trachea is also deviated to the left. That means it's a pulled trachea. Pulled trachea, one of the causes is atelectasis, no doubt, as Shishti said. But the fact that it's a 2-month history points against it. Fibrosis of the left side of the lung becomes more likely. Okay. So very close differential. Good, you guys did give a differential diagnosis, but considering that both are on the same side, hemithorax expansion is also reduced on the same side, trachea is also deviated to the same side, the diagnosis fits more into fibrosis. So one more difference, no, if you want to know clinically, if you want to differentiate between fibrosis and atelectasis is acute, fibrosis is chronic. The other difference is, does the contralateral lung have compensatory emphysema? Compensatory emphysema. So what happens if one lung is not working, the other lung will try and has to overwork. So it will expand. So if it's a problematic lung on the left side, the right lung will overexpand. That's called compensatory emphysema. Okay, so that can only occur if it's a chronic process. The lung can't overexpand in a matter of a few hours or days. So which means if there's a unilateral, you're doubting whether the patient has a unilateral fibrosis or unilateral collapse. If it's a unilateral collapse, you don't expect compensatory emphysema contralaterally because it takes time for it to develop, which means it's more likely to be fibrosis. Okay, these are clinical points, maybe slightly higher order points, but just out of curiosity, you guys can know it. That's all. Okay, good. So this patient basically had fibrosis. So what's happened? The lung has that. The reason why he's not having fever is that now the tuberculosis infection is no longer there. Perhaps there was a past history of tuberculosis. Maybe the patient got treated, but that tuberculosis infection left behind cavities that needed to get filled. So now there's fibrosis that is trying to patch up the gaps in the lung, and that has that has led to the tracheal deviation, the volume loss. So all these are indicating volume loss. If there is hemithorax that is not expanding, if the trachea is deviating, if the shoulder is drooping on the same side, okay, and if there is supraclavicular hollowing, crowding of the ribs, these are all points which favor volume loss. Volume loss could be because of atelectasis. Volume loss could be because of fibrosis of the lung. Okay, another scenario, 50-year-old lady, dry cough since 2 months, dry cough again, low-grade fever, occasional hemoptysis. Otherwise, cough is dry. Okay, so it was dry cough, but occasional hemoptysis. Low-grade fever. Auscultation reveals coarse crepes in the supraclavicular area on the left side. Trachea is central. What could this be? Could it be fibrosis? Now, coarse crepes are there on the left side. Could it be a left-sided fibrosis? Unlikely. Bronchiectasis. Excellent answer. Shishti has hit the nail on the head. Cannot be fibrosis because trachea is central. Instead, there are coarse crepes. Whenever you come across coarse crepes, either think of interstitial lung disease. I mean, most interstitial lung diseases have fine crepes, but some ILDs can have coarse crepes. But otherwise, the other main differential has to be bronchiectasis. So coarse crepes is bronchiectasis. Now, do you guys know what is coarse leathery crepes? Very good. Coarse leathery crepes very much suggests bronchiectasis. Do you guys know what is the name, what is the different about bronchiectasis that occurs in tuberculosis? It's called bronchiectasis sicca. You know what sicca is, right? Sicca means sicca syndrome. Bronchiectasis sicca. So this is dry. Excellent, Shishti. So this is basically dry bronchiectasis or bronchiectasis sicca. So all that fibrosis, what is it doing? If let us say this is an airway, and now there was a cavity here, there's a cavity here. Now finally patient has been treated and tuberculosis has gone away. Now it's getting filled with fibrosis. So all this fibrosis is going to draw fibrous tissue. Its tendency is to shrink. Okay, it's going to cause shrinking of surrounding tissue. So in this process of shrinking, it is going to pull apart the lumen of the bronchi or the airways. So it will eventually lead to bronchiectasis. The airways will expand. So bronchiectasis. Okay, so this is not as a result of a problem within the lumen. Instead, the problem lies surrounding the lumen. That's why it's a dry bronchiectasis. It's called dry bronchiectasis. Within the lumen, there's no necrotizing inflammation for them to be bringing out copious amount of purulent sputum. Generally, bronchiectasis, you think of copious purulent sputum. Not in this. Here it is dry. That's because it's the fibrosis surrounding that bronchi that has caused the dilatation. So it's called bronchiectasis sicca. But hemoptysis can occur because during the process of this kind of traction, there may be certain blood vessels within the bronchi which may rupture. Okay, it's getting pulled, and in this shearing strain, there may be rupture of the blood vessels in the bronchi that can lead to hemoptysis. Okay, so sometimes question asked is, why is there hemoptysis? Hemoptysis in TB. So answers are, one is of course the direct cavity, the cavitation, the caseation necrosis is going to eat away into the surrounding capillaries, surrounding vessels, leading to hemoptysis. Next, there's something called some aneurysm. Can you guys name some aneurysm related hemoptysis that occurs in TB? Aneurysm. Anybody? It's called RAS. Okay. No problem. It's called Rasmussen's aneurysm. So as the cavity is expanding, there's a blood vessel here. Okay, hold on. There's a blood vessel here. This cavity is expanding. Okay, I'll expand it like this. So as it's expanding, it will end up hitting the artery, and it's slowly eroding. It's not directly ruptured it, but it's slowly eroding into the artery. So its vessel will become weak. So it will dilate. So this is known as a pseudoaneurysm. Pseudoaneurysm is because of weakening of one part of the blood vessel. So all the layers of the blood vessel will not be there, right from the endothelium to the adventitia. Not all four layers will be there in this aneurysm. So that's why it's a pseudoaneurysm. So the name given to it is Rasmussen's aneurysm. This aneurysm may suddenly rupture, and that is another reason why patients of tuberculosis having hemoptysis. Okay, that is also a question that is possible as a 3-marker they may ask you. And in clinics, they may ask you this question, why patients of tuberculosis can have hemoptysis. Okay, so this is the fibrosis. This was a tubercular focus, which had ended up, you can notice the tracheal lucency here. The trachea seems to have, this should have been the central position of the trachea. Instead, it has shifted towards the left, and that is because of all the fibrous tissue deposition, and that has caused a pull of the trachea towards the left. Okay, that's another manifestation, tuberculosis. Okay, 58-year-old, uncontrolled diabetes, dry cough 2 months, evening rise of temperature, loss of appetite, supraclavicular. I think we discussed this. I'm sorry, this is a repeat. We discussed this. Matted lymph nodes. No other question. It is tuberculosis. 40-year-old, fever 2 weeks, initial low grade. Then since 3 days, it is high grade. So did you notice that pattern? Since 2 weeks, he was not well. It was running as a progressive disease, but since 3 days, the fever has become high grade. Okay, so sudden deterioration, sudden escalation, progressive fatigue, breathlessness, and anorexia. Chest auscultation revealed crepitations. Fundus exam showed choroid tubercles. Tuberculin skin test was negative. Diagnosis fits into so this pattern where person was anyway going down, was deteriorating, and then suddenly worsened even more aggressively. So since 2 weeks had fever, which now become high grade since last 3 days, and also has progressive fatigue, breathlessness, anorexia. Auscultation revealed Krebs, but fundus exam is the key in clinching the diagnosis. Choroid tubercles in the fundus, in the retina, suggest that the patient has miliary TB. Miliary TB. It spread everywhere. Tuberculosis spread everywhere. Okay. So this is one of the manifestations of tuberculosis. It spread everywhere and therefore produced manifestations like this. Okay, this is milia. Okay, so millet-like. Nowadays, millets are in the news for good things. But with regards to tuberculosis, miliary TB is where you see these kind of very fine, these are all caseous necrosis foci. Okay, very, very small foci which have caseous necrosis. Therefore, they're producing these opacities. Okay, millet shaped, few millimeters only. Okay, 2 to 3 millimeters. this kind of a pattern in the lungs, it's called miliary tuberculosis. Okay, so miliary tuberculosis is when the patient has dissemination of the tuberculous bacillus. The dissemination happens hematogenously as well as lymphatics, via lymphatics. Okay, both. Yeah, are you guys still with me? Only the clinical aspect I was going a little slow. I'll speed it up. Right. So examination wise, I'm sorry. This slide is from pneumonia. I'm sorry. So examination wise, it depends. Now, what do you get? If the patient has fibrosis, you will have fine crepitation. If patient has bronchiectasis, you get coarse crepitations. There may be signs of volume loss if there is fibrosis. Pleural effusion, it will be the opposite. Although the hemithorax expansion will be reduced, but there will be intercostal fullness. Okay, fibrosis, there is volume loss, crowding of ribs. In pleural effusion, there is widening of intercostal spaces and fullness of the chest wall. If it is an ipsilateral pleural effusion, tubercular effusion. Okay, so this slide is also by mistake. I'm sorry. This side is also by mistake. I think I've mixed the. Okay, I think I've put. Okay, from here we are back to tuberculosis. Apologies. It's the last minute PPT, so I could not iron out all the mistakes. So how do you detect? How do you diagnose? Now your suspicion is patient has tuberculosis. You want to diagnose. The preferred modality for diagnosis of tuberculosis currently, as advocated by even WHO, is nucleic acid amplification tests, which have a dual advantage of not just confirming the diagnosis, but also simultaneously detecting drug resistance, especially to rifampicin, specifically to rifampicin. Very good. Arjun has told it correctly. Rifampicin resistance can also be tested simultaneously. In fact, just yesterday, I had a patient who was having intense pleuritis. Okay, in Bangalore, patients or people tend to have a lot of itching. That's how the weather is. It keeps changing. A lot of people don't adapt well to it. They have chronic urticaria. So this gentleman was taking methylprednisolone, 16 milligrams of methylprednisolone, which is supraphysiological dose. Okay, 4 milligrams is the physiological dose of methylprednisolone. Instead, he was taking 16 milligrams just to control his itching. It was over the counter, and he had not revealed this to anybody. He came with history of progressive fatigue, exertional dyspnea, and on auscultation there was nothing. On neither the cardiac nor respiratory auscultation there was no abnormality. Even the jugular venous pulse was normal. So just because of the fact that he was complaining of fatigue and exertional dyspnea, I asked for an X-ray. The X-ray showed a patch, okay, a patch in the upper lobe. So one thing I should highlight is, whereas primary tuberculosis in the mid region, post-primary tuberculosis in the apex. Okay, so post-primary tuberculosis, please remember this point. Post-primary TB tends to occur more often in the apex. That is because when it is reactivated, it prefers a high oxygen area. Whereas when it is an initial infection, it prefers a good balance of both oxygen and blood supply. The post-primary reactivation TB is generally in the apex. So this gentleman had an apical patch. He had no cough, so he was not getting cough. Only in the early morning hours, he was saying some amount of cough is there. When I wake up, I have some sputum. After that, I have no cough. Okay, so I asked him to get the early morning sputum samples tested for CB-NAT. And yesterday, even though he didn't have cough at other times, this early morning specimen showed a CB-NAT positivity. It was positive for CB-NAT and sensitive to rifampicin. Okay, so this dual advantage. Now I don't have to do anything else. I can just initiate him on anti-tubercular therapy, right? So I don't have to, even though the actual plan was to do a bronchoscopy. So I needed a specimen. I thought he may not be able, his sputum may not be giving us positive results. So it may require a bronchoalveolar lavage. But fortunately, just that morning sample itself was sufficient to diagnose him with tuberculosis. And today evening, he was started on anti-tubercular therapy at a government center. Okay, so this is the preferred mode of diagnosis for patients of tuberculosis. What specimens do you need? You need sputum, early morning specimen. So please remember, even if the patient is not having cough, even that early morning when they just have to clear their throat, all they have to do is the overnight secretions may be there, they want to clear it. That is a good enough sample to detect tuberculosis if they are having a positive, a sputum positive TB. Okay, so please don't neglect sputum examination, even in patients who say they don't have cough. Okay, if they're just not having is totally dry cough, then you have no choice. You have to go for bronchoalveolar lavage. You can do a direct bronchoscopy. What you may notice, you should also do a CECT. You can do a contrast enhanced CT before you do the bronchoalveolar lavage, because what this may do is it may show you lymph nodes which are enlarged. If you notice those lymph nodes to be close to the bronchi, then you can do a transbronchial lymph node aspiration or a biopsy. Okay, so you can approach during the bronchoscopy, you can approach the lymph node also. Otherwise, you may notice on the CECT that there are infiltrates. So you'll know better where exactly to focus when you're doing the lavage. Okay, so CECT before the bronchoalveolar lavage is what should be the plan if the patient is not having obvious sputum positivity. So there are these other tests called Expert MTB Ultra, and then there's TrueNat and MTC Plus. These are slightly faster, but not very easily available in India. Okay, you can remember the names perhaps, but practically what we do is CBNAT. Okay, cartridge-based nucleic acid amplification test. Okay, this is the same slide again. Apologies for the mistakes. Okay, AFB microscopy. Now, this has been our previous gold standard, right? So before nucleic acid amplification tests became available, we used to mainly rely on staining. So ZN stain or AFB stain, acid fast staining, or the other way of doing it is using the ormine rhodamine with fluorescence microscopy. This is, unfortunately, it involves expenses. It involves using a dark room and which requires a fluorescence microscopy. So it is an alternative, but expenditure is involved in a country like ours where the burden is so high. This is not very practical. Burden of tuberculosis is very high. Okay, LED microscopes. Now WHO recommends LED microscopes to be used for screening or for scrutinizing smears. Okay, so peripheral smears or sputum smears rather. When the sputum smear is being assessed, LED microscopes are being recommended by WHO. Okay, otherwise ZN stain is what was the gold standard. The problem with AFB is, what if it's a pleural TB? Pleural TB, AFBs. Pleural TB, CBNet, I said 50%. Pleural TB, AFB, acid fast staining positivity is very, very low. Very, very low, cannot be relied on. Okay, so that's why pleural TB takes a hit if you're trying to do it with ZN stain. Practically, I'm telling you, in India, when you get a unilateral, or if you're sure that the patient has an exudative pleural or exudative pleural effusion, well, how do you say patient has an exudative pleural effusion? You remember 3 L's. Okay, you remember 3 L's to be able to say that patient's pleural effusion is exudative. One is, of course, Light's criteria. You guys should read up. Light's criteria in itself is a 3-mark question, and they may even ask you to expand it to 5 marks. Okay, so Light's criteria, please read it, what that is. Beyond that, if it is a left-sided, isolated left-sided pleural effusion, almost always, or in fact always, is exudative. Isolated right side can still be transudative. Okay, I'll tell you why in pleural effusion class. But remember, isolated left side pleural effusion is always exudative. And loculations, when there are loculations, that is also indicative of exudation. Again, this I'll explain in pleural effusion class. Okay, otherwise we'll lose time. So apart from this, if they have pleuritic type of chest pain, that is pleuritic chest pain. The patient has pleural effusion and pleuritic type of chest pain, that means an exudate. It cannot be a transudate. There's inflammation there, that's why the patient is having pain. That means there is exudation and not transudation. Okay, and transudate, exudate, what is it, how to differentiate, we'll discuss in the pleural effusion class. But please remember, AFB was good, no longer recommended as a first line or the ideal investigation to prove tuberculosis, but can be useful in maybe setups where even CBNAT is not available. Nowadays, CBNAT is available even in the remotest of peripheries or government setups. Okay, so that's not an issue in present day. Okay, what are the other ways? Now, slightly slower. At least CBNet will give you the report in 2 hours. Okay, you run a specimen for CBNet in 2 hours. You have the report. You have the rifampicin resistance status also. You can start them on ATT. Liquid culture takes 3 to 4 weeks or 2 to 3 weeks at least, 2 to 3 weeks for it to be able to indicate that there is a growth. Okay, so MGIT liquid culture, the preferred medium is MGIT, that is mycobacterial growth indicator tube. It is based on the principle that if there is oxygen utilization by the bacteria, there is going to be fluorescence, and this fluorescence in that in that tube, in the MGIT tube, will indicate that yes, this patient has, the specimen has mycobacteria, which is why the oxygen is getting consumed and the fluorescence is being emitted. Okay, that's how the principle of MGIT is, but it's slow, 2 to 3 weeks. Okay, the conventional solid media like Lowenstein, Jensen, LJ, or Middlebrook, 7H10 or 7H11, these are going to take a long time, 6 to 8 weeks. Okay, how can we afford to wait for 6 to 8 weeks before we initiate on ATT or before we decide whether the treatment needs to be modified? Because these cultures can also give us an idea of sensitivity, drug sensitivity. So cultures can also be used for drug sensitivity testing. So we can't wait for that long. We need faster diagnosis and faster ways of assessing resistance. So CBNAT, nothing matches it. Rifampicin resistance is determined and you're good to go. You can initiate them on ATT. Rapid immunochromatographic lateral flow assay detects a particular antigen called MTP64. This is more of a higher order point, not common in practice in India, but it is available in the West. So these are the culture methods that you can use to try and detect whether the specimen being cultured has tuberculosis. Specifically to determine drug resistance, you can use line probe assay, and that is what we do use. If you once detect that the patient or suspect that the patient has a drug-resistant TB, you subject for line probe assay, which will detect both INH and rifampicin resistance. In fact, it will detect other drug resistance also. Okay, so line probe assay for specifically for drug sensitivity testing. Now, I told you about latent TB. Patient has an infection, doesn't have the disease. How do you determine the patient has an infection or not? Of course, you can do a tuberculin skin test. It's also known as Montu's test, right? Montu test. You purified protein derivative, you inject intradermally and wait for 48 hours. After 48 hours, you in the antecubital fossa, no? Antecubital fossa, that means basically in the elbow. Okay, in the elbow, in the anterior aspect, you will measure the induration, not the erythema. Induration is measured. Induration in the transverse axis, not in the longitudinal axis of the arm. In the transverse axis, you measure the induration. Generally, what we do is, if this is the arm, we run a pen. Okay, we run a pen across from medial to lateral and lateral to medial. So when the pen stops, because of the induration, the pen will stop. So on both sides, the pen will stop at one point on both sides. So those 2 points, you measure the distance. That will give you the tuberculin skin test measurement. Okay, in a healthy individual, technically 15 mm is the cutoff. Okay, in a healthy individual. Okay, but the cutoffs vary based on immune status and whether the patient is on certain drugs like steroids or TNF alpha inhibitors. Okay, you can remember 5 mm cutoff. Where all 5 mm cutoff is used? It is choice. You can remember it as choice. C stands for patient having tuberculosis, patient having comorbidities. Comorbidities such as uncontrolled diabetes, dialysis, hemodialysis patients. So in hemodialysis patients, you do a TST, and if that is of even 5 millimeters, then the patient is considered to have a latent TB infection. Okay. H stands for HIV positive individuals. O stands for organ transplant. Okay, organ transplant. So patients who have received solid organ transplants, not hematogenic stem cell transplants. So if such individuals have 5 mm, then it is significant. Immunocompromised or immunosuppressive drugs. Immunosuppressive drugs like steroids or TNF alpha inhibitors. These can also lead to, I mean, these in such patients also, if they have a positive skin test of 5 then that is considered as significant. Okay, the other C stands for close contacts. Okay, contact with tuberculosis, household contact. Okay, so that is what I meant. If a patient now in India, if a patient is being started on ATT, their contacts will be traced, household contacts. They will be subjected to IGRA. That is positive. If they're above 5 years of age and don't have the other issues, the other comorbids or other reasons for low cell-mediated immunity, then they are subjected to IGRA. And then if it's coming positive, then they are also started on INH prophylaxis, 6 months of INH prophylaxis. Eliminate TB is the goal right now. The last is end stage lung disease. End stage lung disease, which is a fancy modification for fibrosis. Okay, so if a patient has lung fibrosis and has a tuberculin skin test with measurement of more than 5 you have to consider the patient to have an infection, latent tubercular infection. Okay, so this was about MAN2. IGRA, interferon gamma release assay. What you're doing is you are subjecting the patient's plasma, which should have some macrophages. Patient's plasma, you are subjecting or exposing them to the tubercular antigens, ESAT6, okay, TB 7.7, and culture filtrate protein 10, CFP 10. Okay, so these, when the macrophage sees them, it has recognized it already in a patient. Okay, the patient's plasma has been taken, or the blood has been taken rather. Patient's blood, which contained macrophages, if the patient had tuberculosis, the macrophage would instantly recognize these antigens, and it'll liberate interferon gamma. So interferon gamma levels will increase in the test solution. So which means you are measuring the interferon, the quantitative measurement of interferon, which will indicate that the patient has a latent tubercular infection. If you're sure that the patient doesn't have a clinical disease, you just want to find out if they are exposed or not. When you're traveling to the US, they will ask you to undergo this test. This is the principle of it. Okay, and it's not necessary that if a quantiferon gold test is positive that the patient has tuberculosis disease. It's just an infection. Okay, so one need not be too worked up just because it came positive. Okay, final aspect, treatment. Right, so anti-tubercular therapy, you all know from pharmacology days what the first line anti-tubercular drugs are, HRZE. Right, so we have an intensive phase and we have a continuation phase. Hit hard, hit early, hit hard. That is the intensive phase. You want to take out as many of the virulent tubercular bacilli as possible. That's why you go hard in the first 2 months. So 2 months of intensive phase followed by 4 months of continuation phase. This is for pulmonary tuberculosis. A lot of times, skeletal tuberculosis or CNS tuberculosis requires or mandates longer therapy. But for pulmonary tuberculosis or even pleural tuberculosis also, 6 months is usually sufficient. Okay, so pleural tuberculosis is slightly tricky. I told you CBNAT may not be positive all the times. AFB is abysmally low, very low rates of AFB positivity. Many times you have to start them empirically. Pleural tuberculosis, you can start empirically. You can use certain additional certain additional parameters to help you make that decision, like ADA levels. So pleural ADA levels, if it is greater than 40, generally it indicates 40 units, it indicates tuberculosis. You can also measure the pleural interferon gamma or interferon levels. So elevated pleural interferon levels and ADA levels, these are additional points which may help you to diagnose pleural TB, because CBNAT levels, CBNAT positivity itself is low. Okay, so but duration is 6 months. INH, rifampicin, pyrazinamide, ethambutol. You guys are well versed with these, right? So INH and rifampicin, they target both intracellular and extracellular tubercular bacilli. Pyrazinamide is meant for intracellular bacilli. Ethambutol is meant for extracellular bacilli. Okay, and rifampicin works very well for extracellular bacilli. Rifampicin is ideal for, and that's why pyrazinamide works very well for extracellular bacilli, and that's why we have to use it in the first 2 months intensive phase where there is caseation. All those bacilli may be hiding within the caseation, so that needs to be targeted. That's why you use this. Side effects you all remember. INH, very important. Practical point, I'll just tell you guys. When the government issues, if you refer the patient now, it's mandatory that every patient of tuberculosis who's receiving ATT has to be registered with NTP. That is mandatory. If you don't do it, you are liable for legal, at least you can be prosecuted. Okay, so please remember, whenever you, even if you're privately initiating a patient on anti-tubercular therapy, just get them registered in an NTEP setup. After that, you can initiate the ATT if you want. It's okay, but they must be registered. But it's always safest to just leave it to the government to treat them. Okay, at the government center only, they'll take care of the treatment. But what I was saying about is pyridoxine. Pyridoxine is not given in most government centers. So you have to keep in mind, if a patient is receiving INH, please make sure they're also receiving pyridoxine. Pyridoxine has to be co-administered with INH. Otherwise, the patient can land up with peripheral neuropathy, can land up with seizures. They can land up with hepatitis also. Hepatitis, pyridoxine doesn't protect against. So INH can lead to INH toxicity or INH side effects. Peripheral neuropathy can lead to seizures, can lead to lupus-like. So drug-induced lupus can lead to hepatitis, of course. Hepatitis. So keep that in mind when you're starting INH. Rifampicin can lead to flu-like syndrome. Redmond syndrome can lead to cholestasis, and therefore it's hepatotoxic. Okay, cholestasis. So bilirubin elevations are generally higher with rifampicin. Bilirubin for rifampicin, whereas it is the ALT rather for INH and pyrazinamide. Pyrazinamide is also hepatotoxic. So the first three are themselves hepatotoxic. So you need to monitor, especially in alcoholic patients who've been started on ATT, you have to monitor the LFT very regularly. Okay. Ethambutol, can you tell me one side effect of ethambutol? I'll wrap up in 5 minutes. Okay. Ethambutol, one side effect. Particularly, you're worried in children because they're not able to report it. A child is diagnosed with TB, start them on ethambutol, you're worried that they may not be able to report it. Okay, hyperuricemia is a common side effect actually. High uric acid levels. That is common to both ethambutol and pyrazinamide. Excellent. So I said optic neuritis. Okay, optic neuritis, color blindness. So they may, and it's a cause of acquired color blindness. Okay, one of the drugs which produces color blindness. Sildenafil is the other drug that produces color blindness. But even ethambutol can lead to optic neuritis. And the patient, if it's a child, they may not be able to express it. And that's why you're worried. You have to be extra cautious in children. Okay. One point I'll just tell here about body weight. So all these are weight based, right? I'll put it as EZ for now. Otherwise, we remember it as HRZE. So it's usually 5 milligram per kg per day for isoniazide, 10 for rifampicin, 15 for ethambutol, and 25 for pyrazinamide. Right? This is the daily per body weight dose. So weight has a lot of importance in body weight, lot of importance in tuberculosis. Weight loss is one of the constitutional symptoms of tuberculosis. When you start the patients on ATT, you are going to do it on a weight-based dosing. So you need the weight to be able to decide how much of ATT to be given. And post-ATT initiation, weight gain is a very good indicator that the patient is responding. So in patients of tuberculosis, weight measurement is very important. Before diagnosis, the patient themselves will complain. At diagnosis and initiation of ATT, and then post initiation to see if the patient is responding or not. Okay. What are the second line drugs? They are classified into group A, group B, group C. Group A, you can remember the names because this has been asked. I doubt that they will ask you regimen for drug resistant TB, but at least the drugs you should be able to remember. The first line HRZD. Second line group A is the respiratory quinolones, levofloxacin, moxifloxacin. In fact, ofloxacin is also mentioned as a antitubercular quinolone, but generally these two is what we use for drug-resistant TB as a second-line agent. Linezolid, okay, surprisingly, linezolid is also an antitubercular drug. Bedaquiline also. Okay, so these are Group A second-line antitubercular agents. Group B second-line antitubercular agents include clofazimine and cycloserine. And Group C includes all the rest, including, so this is obviously ethambutol and pyrazinamide are first line, but when treating patients of resistant tuberculosis, we include them as Group C drugs. Okay, so when the patient has drug-resistant tuberculosis, these also become second-line agents as Group C. Delaminid is the other relatively new antitubercular agent, right? So bedaquiline was one, and delaminid was the other. They were developed just a decade ago, just over a decade ago. They were the freshest antitubercular therapy that we have. Now, just like linezolid, other antibiotics like imipenem, cilastatin, and meropenem are also considered to have antitubercular therapy. Streptomycin is amikacin. Okay, so streptomycin was earlier considered a first line, but no longer so now. Okay, streptomycin is a second line agent. And PAS, so paraminosalicylate, salicylic acid, that is again a second line agent. Okay, so names of the drugs, please remember. And regimen, now MDR TB, MDR means patient is resistant to both INH and rifampicin, both. Okay, so in that case, what drugs can you use? So funnily, you can still use high dose INH. Okay, though the patient has resistance to INH, you can still use high dose INH. Apart from that, bedaquiline is included. So this is the intensive phase for MDR therapy. You use bedaquiline, you use high dose INH. You still use ethambutol and pyrazinamide, which are first line agents. Apart from these three other agents, that is levofloxacin, that's a respiratory quinolone, clofazimine, and ethionamide. Clofazimine is actually an anti-leprosy drug, but that also has some amount of antitubercular activity. That's why it's a second line antitubercular agent used for resistant tuberculosis. Okay, ethionamide is also included in the regimen. This is the intensive regimen, usually for 6 months, followed by another 5 months of the 4 of these. Okay, levofloxacin, clofazimine, apart from EZ, that is ethambutol and pyrazinamide. So 9 to 11 months. Okay, so generally the entire course is 9 to 11 months. Continuation phase is fixed at 5 months. The intensive phase you can vary between 4 to 6 months. Okay, drug-resistant TB, as I said, drug resistance is when the patient has resistance to INH and rifampicin. XDR TB is defined as resistance to HNR, of course, that means MDR TB only, along with the respiratory quinolones, fluoroquinolones, along with the Group A drugs, Group A second line agents, that is linezolid, bedaquiline, and levofloxacin. So, or respiratory quinolones, that is. So, respiratory quinolones are anyway covered here. So, bedaquiline and linezolid resistance. So, this is considered XTR TB. Okay, extensive drug resistant TB. Okay, I think that was my last slide. Clear? Are there any doubts? I'm sorry, today also I thought I'll finish by 10, but I ended up extending beyond. Okay. Shall I ask, the patient must be isolated during the 6 months of treatment or just the first months? Okay. So isolation for patients with for MDR tuberculosis, or you mean just tuberculosis, is it? If you're asking about general tuberculosis treatment, the thing is now we are not isolating them since the patient's close contacts are also going to get treated. So patients with tuberculosis, they are encouraged to have a home isolation if they are going towards their workplace. Unless they're MDR tuberculosis, they need not be isolated. They can use the usual precautions with wearing a mask. Okay, but otherwise at home, whoever else is a close contact will be tested and treated themselves. So isolating them at this point is not a necessity. unless they have MDR or XDR TB. Only if they have MDR or XDR TB, then until the patient is declared cured, which is difficult. Okay, it will be an extensive treatment, 11 months of course, and then retesting to determine if they have had a cure or not. Only then you can deem them to be safe. Otherwise, for in general tuberculosis patient, they can go about their usual work. They just need to use a mask. They need not have to be home isolated. And all those who are at home will anyway be treated with isoniazid prophylaxis, chemoprophylaxis for 6 months. But please remember to give them pyridoxine when you're giving INH. Okay. Any other questions? Sorry, something unplanned came up today, so I couldn't prepare MCQs. What I'll do is now, since the next class will only be next week, in between I will put up MCQs in the WhatsApp group for you guys to be able to answer, and I will share the annotated notes also. I'll edit whatever mistakes are there. I'll iron them out and give you the final notes with annotations. I'll put that also in the group. Was the actual reason for weight loss and loss of appetite in TB. Okay, so in simplest terms, why is there weight loss in tuberculosis? So there is inflammation, right? So I'm sorry, this inflammation is going to be mediated by certain inflammatory mediators. So one of the most important mediators of inflammation is TNF alpha. TNF alpha has an anorectic effect. It will reduce appetite. And this is the reason, not just behind loss of appetite in inflammation, it is also the reason for cancer cachexia. So TNF alpha is what mediates cancer cachexia. Patients of cancer will have cachexia. And the reason behind that is TNF alpha. And even in heart failure. So in patients of heart failure also, they have cachexia. So any patients, basically even cancers, even heart failure will have some amount of inflammation. And that is where TNF alpha gets involved. And that reduces appetite. But even in simpler terms, if you want to think about it, if a person has something within their body that is growing, whether it's cancer, whether it's an infection, something is growing. So for its growth, it needs nutrients. So it is going to drain nutrients from the body. Okay. And as a result of that, they will end up losing appetite and losing weight thereafter. But if you want a more scientific explanation, it's the TNF alpha. Okay. And the TNF alpha liberated during inflammation in cancers, it's called cardiac cachexia, no? Heart failure, loss of weight and loss of appetite is called cardiac cachexia. So all that is, everything is mediated by TNF alpha. Okay, so the moment you start them on ATT, this inflammation starts subsiding, they start gaining weight. So one of the earlier indicators of successful response to ATT is weight gain. Fever defervescence is also early in tuberculosis. By maximum 2 weeks, their fever would have come down. If beyond 2 weeks you start ATT and they're not responding, the fever has not come down, you have to revise your diagnosis, revisit your diagnosis, perhaps even revise your diagnosis. Okay, so you expect defervescence by 2 weeks maximum. Most often it will happen in the first week itself, but at least by 2 weeks, the fever should have gone. And then weight gain. So weight gain is the other indicator that they are responding to ATT. Weight has an important role in TB.